In recent years, overlapping crises and pandemic-related mass casualties have produced an immense volume of precipitating loss events. Grief is a universal human experience, but for a specific subpopulation, the normal mourning process does not eventually resolve. Instead, their psychological momentum comes to a complete halt. In 2022, the clinical community recognized this distinction by formally adding prolonged grief disorder, or PGD, to the DSM-5 TR. Data shows that approximately 7 to 10% of bereaved adults develop this specific condition. When a patient remains in this state, they have reached a clinical arrest. PGD is a discrete, recognizable condition that responds to specific interventions rather than the simple passage of time. Look at this chart mapping symptom intensity over time. In acute grief, emotional pain spikes initially, but slowly tapers downward toward a baseline as the individual integrates the loss over several months. But with PGD, that integration phase fails. A distinct trajectory emerges where symptom intensity plateaus, staying elevated and flat well past the 6 and 12-month markers. This plateau represents a temporal and emotional arrest. The patient is firmly stuck in their grief, distinctly different from major depressive disorder. While depression is characterized by generalized anhedonia, the primary driver in PGD is an intense, specific focus on the loss itself. If a practitioner fails to distinguish PGD from generalized depression or normal mourning, standard clinical treatments will be misapplied, and ultimately they will fail. This diagnostic matrix outlines the exact criteria for PGD. The foundational threshold is temporal. For adults, symptoms must persist for more than 12 months post-loss. For pediatric patients, the timeline is shorter, requiring symptoms to persist for more than 6 months. Certain precipitating events carry a significantly higher risk of triggering this prolonged state. These typically include sudden or traumatic deaths, the loss of a child, suicide loss, or a death following a long, taxing period of caregiving. Building upon that temporal foundation is the core, mandatory clinical feature: an intense, persistent yearning for the deceased. This intense preoccupation often manifests as an exhausting cognitive loop, where the patient's thoughts continuously circle the exact circumstances of the death. Without both the strict temporal bedrock and this core engine of active yearning, a clinical diagnosis of PGD cannot be validated. Alongside that core yearning, a specific threshold of secondary symptoms is required. A patient must actively exhibit at least 3 of 8 markers. The first is profound identity disruption, where the patient feels a literal part of themselves died. Next is a persistent sense of disbelief regarding the death, combined with extreme avoidance of any physical or social reminders of the loss. This is often accompanied by intense, radiating emotional pain, or conversely, severe emotional numbness. Patients also face marked difficulty reintegrating into daily life. Social circles, careers, and personal interests are left abandoned. Finally, there is an overarching sense that life is now meaningless, coupled with intense, isolating loneliness. To qualify, this cluster of symptoms must significantly impair the individual's daily occupational or social functioning. Documenting at least 3 of these 8 symptoms proves the patient is suffering from profound identity arrest, rather than an extended period of sadness. Identifying this specific matrix of symptoms presents a serious operational challenge during a busy clinical intake session. Look at this comparison. On the left is a generalized psychological intake form, but on the right is the PG-13R, a validated screening instrument designed specifically to isolate grief metrics. The PG-13R maps directly to the DSM-5 TR criteria, allowing practitioners to mathematically separate PGD from general depression. Generalized supportive talk therapy often fails here because it is not structured to resolve the deep identity disruption driving PGD. Similarly, standard pharmacological or therapeutic depression protocols are ineffective against the active yearning component. Utilizing the PG-13R is the necessary evidence-based bridge between recognizing a patient's subjective pain and prescribing the targeted clinical intervention they actually need. Once the stuck state is identified, clinical focus must shift to the specialized treatments proven to resolve it. Prolonged grief disorder therapy, or PGDT, serves as the primary targeted intervention. This includes complicated grief treatment, developed by Dr. Catherine Shear, which provides a foundational, evidence-based approach to the disorder. Grief-focused cognitive behavioral therapy is another highly effective, distinct modality. The mechanical difference with these therapies is they actively focus on restructuring the patient's relationship to the deceased, untangling the complicated narrative of the death. Treatment is never about forgetting the loss. It is about successfully rewiring the brain to integrate that loss into a continuing, functional life. Delivering this effective intervention requires highly coordinated detection network at the very front lines of healthcare. This network map illustrates the pipeline. Hospice teams, palliative care units, and primary care physicians act as the primary nodes, identifying at-risk individuals and funneling them toward a PG-13R screening. Once a positive screen occurs, the patient must be rapidly connected to specialized grief therapy. Specialized telehealth provides the modern solution to this, effectively removing the geographic and logistical barriers that often prevent access to care. Coping and Healing Counseling, or CHC, is a premier, fully HIPAA-compliant telehealth practice explicitly equipped for this clinical pipeline. They serve all 159 counties in Georgia, utilizing